Okay, I am also colleagues of people, a previous speaker. Okay, so we move on to our topic. So sorry for the point. Okay, so the topic of today is managing necrotic immature teeth. What to do in this era. Okay, before we start, we have to think about why do we need to know about this topic, and are there anything interesting? Yeah, because I'm not really sure that you guys or dentists here in Vietnam get used to this topic or the treatment of this kind of thing. It is interesting nowadays, starting in 2004, that Brand Central introduced a treatment technique in immature necrotic teeth. In this study, they tried treating necrotic tooth which have sinus tract and periapical lesion with this technique, and then he found the tooth maturation after the treatment, which it shows the tooth have thickening root and also the tooth length is improved. The technique that they call is lesion sterilization, which introduces tissue repair using premix antibiotics. Since then, in 2004 until now, 2020, there are lots of things happening. Start from the case reports in the earlier part, and also start to have some of the experimental study, outcome study, which leads to lots of pros and cons. And now it makes us to discuss what should we do. It's start to have lots of controversy nowadays. So the scope of this talk would be, I will have to tell a little bit of background because I'm not sure whether you are familiar with this kind of things. So I have to start with the causes of necrotic pulp in immature tooth. And also we have to remind about the concept of the treatment to go together with some techniques. And also I have to update some current evidences nowadays. To start with the causes of the pulp necrotic. To date, there are various situations that can be occurred in the children, including dental trauma, dental caries, and also dental anomalies, which may relate to the dental pulp. All of these things can develop the necrotic pulp, which in the dental anomalies and also the dental trauma can make the pulp necrotic the worst. Okay. So what are the consequences after these things? So the root of the tooth start growing, which lead to thin root and thin of the tooth root. And also with the short root and wide open apex, it is difficult to have a root canal treatment in a conventional way. So there are some guidelines that introduce the technique to treat this kind of tooth with necrotic pulp. So normally they have two things. The first one is a root end closure technique, and the other one is the pulp regeneration. To start with the root end closure technique, so you may understand that there are different ways to close the root. So maybe here, all of the students may get used to the treatment using the traditional apexification with calcium hydroxide. And the other one is the treatment using one visit apical plug, or maybe we can call it an immediate apical barrier. For the treatment of using the traditional techniques, normally we use calcium hydroxide to put inside the tooth, and then wait for a while until we get the apical barrier formation. But for the one visit apical plug, we normally use something to create an immediate barrier at the end of the tooth root. With these techniques, we achieve about almost 100% success, but however, the different things between two of these is the time that we have to wait. Because in the traditional apexification, we need sign than the immediate apical plaque. Here is an example of a traditional apexipation. The first visit, we normally do disinfection using some irrigant without severe mechanical debridement because the tooth itself is pretty thin. And after that, we place the calcium hydroxide inside and wait until we get a barrier formation at the end of the tooth. So we have to wait, maybe in this case, we wait for about a year to get the barrier formation, and then it's ready for obturation and finished with the canal treatment. However, it is very difficult to predict when to finish the treatment, so it would be very difficult to tell the patients that when we're going to finish and when we have to do other things else. Okay, so there are many factors that are related to the success of this kind of treatment. For example, the presence of her apical lesion, rate of percentage spine change, apical width, age of the patient, and also the presence of the symptoms. There are also undesirable findings after the treatment using calcium hydroxide. For example, we may got the wrong barrier location. Actually, we would like to get a barrier, maybe to this one. Yeah, to get the barrier at the end of the root. But sometimes we place the calcium hydroxide in a different position. Maybe we get the wrong position of the barrier that we would like to achieve. Sometimes we also get partial calcification, almost complete obliteration. Sometimes root fractures because of calcium hydroxide. If you put in the root for a long time, it may reduce the strength of the root. And also maybe no barrier formation. So one visit apical plaque would be another option for you by placing the immediate apical barrier at the end of the tooth root. So there are many types of materials that we can use nowadays. But the technique that I just briefly tell you that it's just have to start with the thinning first, like traditional calcium hydroxide, and then after it's ready, we place with the barrier at the end of the root. And then after finish this, we can get the first shot to fill the root. Okay, so the important things for this technique is to create a good seal at the end of the tooth root, which normally takes about 3 to 4 millimeters. So nowadays, we have many types of barriers that we can use. In the past, we may use dentine chips. Some people use hydroxyapatite, and some people start using other materials. But the most important things that we are normally used nowadays is mineral dioxide aggregate, or MTA, that you may get used to this word for a while for today, and also biodentin. Both of these can provide good sealing ability and strength. However, the use of biodentin nowadays is interesting because it is easier to use than MTA. If you can have a chance to try, you may think that it is easier in handling. So for sealing ability of this barrier technique, so there are some literatures compare the efficacy of MTA and biodentin on their own, but on bacterial micro leakage. So in these studies, they tried placing MTA and biodentin at different thickness, 2 millimeters and 4 millimeters, and after that, they test for the microbiological leakage using efficacy. From this study, they found that MTA and biodentin can provide similar results. And if you want to use the biodentin, it is recommended from this paper that 4 millimeters of thickness is better than 2 millimeters. So if you would like to use biodentin as an apical barrier, just place it for 4 millimeters, okay? For the leakage, it is also important in this part because we would like to know that this material can provide enough bacterial leakage. So in these studies, they place MTA at the top of the root, the end of the root, and then they place the gutta at immediate after, 48 hours later, and also 1 week later after waiting for setting. From this study, they found that MTA can provide better, prevent leakage better if you wait until 48 hours or 1 week later. So it means that from this study, we can answer the question that when to fill the gutta percha after the apical barrier formation, it says that we should wait until it's completely set, not immediately after placing the apical barrier. Okay. Next is for the spring. Okay. Before that, we talk about leakage. Before that, we talk about the thickness. So now we are focusing on the spring. So the MTA, it will be placed in the canal for 3 millimeters, 6 millimeters, and also in full length, provide different things. 3 millimeters and 6 millimeters of MTA can provide better strength than the full length. It is quite interesting to see that. So from this study, they recommend that if you would like to place MTA as an apical barrier, you just place it not full of the length. Okay, just 3 to 6 millimeters is enough to provide a good strength for you. However, even MTA apical plug or apical barrier technique is a good thing and easy to do and also quick, but still have undesirable findings. Okay, for example, the over extrusion of MTA because the tooth itself is a little bit wide and large. So if you just place MTA without any concern, you may push the MTA through the end of the root. Some little, some a lot. Okay? But maybe if you are just too aware, it may be just too short in the filling. Or maybe it just if you're just too aware and you just go gently pack it in, it may create some more at the end of the root. Okay? So it is need time to practice. For the extrusion of MTA, so we have something to prevent the extrusion by using a collagen matrix at the end of the tooth root. We would like normally place the collagen matrix a little bit over of the tooth root, and then after that we place the MTA after that. Okay. It is very helpful. So if you have something, because I went through the exhibition and I found lots of booths that are selling this thing. So it is also good to use something like this in this kind of treatment. So here is an example of the MTA apical plug case. So here's a pre-operative operation with our pretty wide view. And after that, we place the MTA inside. If we just careful enough, the MTA can be placed very nicely at the point that we really want. Okay. See, okay. So if we compare two techniques for root end closure, both the traditional calcium hydroxide emulsification and MTA apical plug, it seems that both of these techniques give successful outcomes. It can reduce signs and symptoms, so patients will feel okay after the treatment because the tooth was already clean, and the tooth can survive in the patient's mouth. However, there is no changes in root thickness, so it means that root will stay at that point. Therefore, if the root is still like that, very thin and very short, sometimes it will have a chance to have a tooth fracture. And also with the long-term calcium hydroxide acidification medication, it may reduce the strength of the tooth root, which create something like the tooth is a little bit more fragile after that. So let's come to the other question. So because since there are various techniques that used in the past and also maybe currently now using, are there any other techniques that can improve the tooth strength? That's why we are here talking about pulpal regeneration. These techniques has been in our field for a while, about 15 years or 20. These techniques can improve the pulpal healing, and also it can improve the root, thicken of the root, and also strengthen of the root. So, and also it can provide the pulpal repair or regeneration inside. So the definition of this technique, it calls that it's a biological based procedure that is designed to place damaged structure, including dentine and root structures, as well as the pulp-dentine complex. This technique uses the concept of tissue engineering that composed of three things: cell, signals, and scaffold. Three of these things work together to improve the tissue generation. As I mentioned earlier, that this technique was done since 2004. Okay, and at that time, Branch and Tro introduced this technique and found that the tooth can be developed after the necrosis occurred. Then, that time, it calls this technique as a pulp revascularization. After that, this term has changed, okay, to regenerative endodontics because it's provide a little bit more area of interest. And also after that, there are many teams that would like to name it. So this group of technique recommend to use the term revitalization rather than revascularization because the tooth would like to have a tooth vitality improvement. Yeah, so they just say that we better use this term rather than just got the vessel inside the tooth. After that, AAE and also endodontics around the world interested in this kind of things and recommend to use to include these techniques in the endodontics program. Okay, so if you think about this technique, we have to think that if the tooth becomes necrotic, it means that the pulp inside the tooth is already dead. But how can the cell or how can the tooth can grow after the treatment? So we have to think about cells or situation that improve the tooth development. So we are looking at cells which may play a role in this kind of technique after the treatment. There are different types of cells I mentioned in this field. For example, the dental pulp remnants, which may survive after the tooth got infection, and also the cells at the end of the root, which may be some stem cells located in the vertical papilla or cells in the herping epithelial root sheath. These kind of cells has been mentioned that to play roles after the treatment using regenerative endodontics. So now we come to how to technique. Yeah, because before that we talk about the background and also some of the biological things that may be related to this technique. So how can we do this technique? There are many guidelines from the big association, for example, American Association of Endodontics and also European Society of Endodontics. I just briefly tell you, maybe we just, so you just can understand the big pictures of this technique. So in the previous, in the earlier, the first appointment, you can say that the tooth should be irrigated with some disinfectant, with or without instrumentation, because the tooth itself is pretty thin. So if you just have to use file or something to clean a lot, the tooth will be a little bit thinner and thinner, and we're gonna weaken the tooth. After irrigation, we put the medication inside to clean. And after that, wait for a period of time. And the second time that we see the patient, we're going to generate the bleeding inside the tooth and then see. So we just can simply say that the phase of the treatment can be separated into two parts. The first is a disinfection phase, and later is a regenerative phase. So we focus on the disinfection phase first. So the disinfection phase means that we have to reduce the bacteria that causes tooth necrosis. And after that, with the concept of lesion sterilization. Okay? So reduce the bacteria inside the tooth may create an environment for tooth or environment for tissue around the tooth that can be generated or something, creating tissue repair. And after that, we have to concern about conservative technique because the tooth is pretty thin. So we should not use the aggressive tooth extraction mechanical preparation. Also, we have to keep the viable cell around the tooth because as I mentioned earlier that the cells around and inside the tooth may play a role in root generation. So the technique used should have a non-invasive technique. So it means that the medication or irrigant used should have a very less toxicity. So here is the technique. So we use 1.5 to 3% of sodium hypochlorite to irrigate the canal using side-vented needles to prevent extrusion of irrigant, and beware that the irrigant can destroy some cells around the tooth. So it is recommended to position the needle at 1 millimeter from the root end. After that, irrigated with normal saline or EDTA for 5 minutes. So here is an example. After that, dry the canal and place the medication. So for the medication, we have to think about that. There are two types of main medications that using nowadays. That is calcium hydroxide, so one, and the other one is an antibiotic mixture. We have to talk about the antibiotic mixture first because it may be not common medicament that using nowadays. So the antibiotic mixtures that we are using called free mix is composed of the three types of antibiotics that are ciprofloxacin, metronidazole, and minocycline. Okay, so please, the video cannot. Okay, free mix preparation can be done by using the over-the-counter antibiotics. Okay, so if it is working, you can see all the movement, but now we cannot see the movement. So you just see that you just look closely. We use just normal medicine and use the dental blade to scratch the medicine into a powder. And also in the one with the capsule, you have to just open up and then use the medicine inside. Then after that, you mix it at 1:1:1 ratio with the propylene glycol and then make it as a paste. Okay? Some recommendation recommend using lentulose spiral And some recommend using the syringe to place the medicine inside too. But however, there are some concerns because antibiotics itself seems to have some toxicity. So in the literature and our study, we focus on the toxicity of this kind of medicine. And we found that if we use it at a higher concentration, it will reduce the cell viability. So that's why we have to concern about the concentration of the medicine. Also, these premix or also antibiotics can create a tooth discoloration. So in this study, they compare premix and separate drug and compare the color changes. And we found that the minocycline is the one that makes the tooth color change. Okay, so we have to just be careful of using minocycline. There are also another study that compare the change of the color after placing different types of medicine. In this study, they try to compare triple antibiotics using minocycline and triple antibiotics that change to doxycycline or change to amoxicillin or change to cefaclor. And in this study, we found that all triple antibiotics groups show color changes, but the most changes was found in the minocycline group. However, with the use of double antibiotics, it means that without minocycline, it generates a good color stability. So it may be another option to use in this kind of case. So there are some concerns there. Because I mentioned that the antibiotics have toxicity and also create color changes, so the recommendation from AAE 2021 mentioned that we have to use these antibiotics at low concentration at 1 to 5 milligrams per ml, and also limit use in the canal space. Put it below the CJ. Sometimes we can apply the dentin bonding in the cavity to prevent the penetration of medicine. And also you can change minocycline to other drugs instead. Okay. Okay. So here is another example of changing medicine to other things, and then use other techniques, other developmental advanced techniques to create the medicine. In this study, they used electrospinning to generate the ready-to-use medicine, and they found that they can generate a nanofibromycin. And this medicine is stain-free, has antimicrobial activity, and also cell-free. So maybe we're going to have this be used in the future. Okay, so when compared to premix and calcium hydroxide, so if you remember, I mentioned two main associations that interested in this field, which is ESE, European, and AAE, American. So ESE recommend to use calcium hydroxide rather than antibiotics because of the drawback of this thing. So because calcium hydroxide, from the studies that they mentioned that it can improve cell survival if we use in the right concentration. So in this study, 1 milligram per ml of calcium hydroxide can improve cell survival. And also calcium hydroxide can improve cell attachment. Here is an example of our study using calcium hydroxide cover on the dentin, and we found that after we glue cell on the top, cells attach beautifully. Okay, so we come back to the technique. So at first we rinse, dry, and then place medication. And after that we place a temporary restoration. After that we wait for medicine to work 1 to 4 weeks. And then comes to the next phase of the treatment. So the next phase of the treatment is the regeneration phase, which we have to create bleeding inside the tooth. But before that, the tooth should have no symptoms, no signs and symptoms. And in this part of the technique, we would like to promote the regeneration inside by creating bleeding as a scalpel for cell inside. So the technique, we have to give the patients with 3% methylated with our vasoconstrictor first, because it's going to be painful in this stage. And if we use with vasoconstrictor, it may disturb the bleeding that we would like to generate. After that, rinse with 17% EDTA gently, and also rinse and time with normal saline. After that, dry. Okay. So at this point, the things that we consider as the technique of irrigation. We can normally use the needle to irrigate the canal, but there are some recommendations that if we have dynamic movement of the lubricants all the time, it can improve the cell attachment. Okay, so if you want to rinse the root canal in this kind of case, we may just easy to use the movement of the needle. Only maybe you just can use some equipment that can generate the movement of the liquid. But anyway, you have to be careful of extrusion, because when you use this equipment, it may be generate lots of force that may extrude the organ outside the tooth and generate the toxic to the cells around. So there are some studies focused on this, and then they said that the sonic movement, can generate the most extrusion of the organ through the tooth. So anyway, the dynamic movement is good, but you just have to pick up the right one to use for this technique, just to prevent the over-extrusion of the organ. Then the tooth should be ready, okay? Ready for blood clot stimulation or bleeding stimulation. We normally use the pre-bent K-file to insert into the root, okay? With you have to aim that the file gonna go pass through the apex, and then twist, generate some trauma around the root, and then the bleeding gonna be pushed up into the level that you want. Okay, so after that, you just have to wait the bleeding to be a little bit clot for about 15 minutes. After that, ready for the next one? We place a collagen membrane on the top, and then place some bioactive material, which may be MTA or biodentin on the top. The reason of using collagen membrane is just to prevent the extrusion of the skin into the canal. Okay. And then place it with some restorative material. The concern that we have to create a very good seal after the treatment. Otherwise, we're gonna get reinfection through the tooth and maybe disturb the outcome. However, there are some techniques that can use not only the bleeding generation or blood clot formation. So we can use the platelet-rich plasma or platelet-rich fibrin, as the previous speakers mentioned before. So we just go quickly through this. Actually, the platelet-rich plasma therapy can use by drawing the blood from patients and then spin, and then separate the blood vessel and separate the red blood cell, and then after that we get the fibrin and plasma. Okay, which is plasma because no. So after we got this, we place it inside the tooth, like this. Yeah, after bleeding formation and then we place this, it may improve the outcome. So we can see from the literatures nowadays that they mention using of this PRP and PRN and these techniques. And they found that, go quickly, yeah. And they found that the tooth after the treatment with this kind of scalpel, it creates the asymptomatic and can generate the apical closure, also provide root length and root thickness in the good level, and also can improve the tooth vitality response. There are some studies that try using PRP, PRF in the technique and mention that if we use this, it can improve the vitality positive outcome. Okay, from this, we just have to say that after finish everything that I mentioned, have to do the follow-up. What do we expect after this? So we see what nowadays there are assets. Various researchers and also scientists would like to create the guideline for success. And they mentioned that we have to think about the pyramid of success, which the patient would be the main, and the dentist would be the other one, and the last one would be the scientist. So for the patient center, we have to think about the tooth survival after the treatment. And for the dentist, we expect to see the root maturation after the treatment. And for also the scientists at the top, at the tip of the pyramid, we would like to get the real pulp regeneration after treatment with this technique. Therefore, for the dentist point of view, ESE recommended you to follow up after the treatment using this timeline, 6, 12, 18 to 24 months, and regularly after that for 5 years. We have to see for the sign and symptom improvement by seeing the reducing inside of the periapical lesion, and also have a PDL generation around the tooth without root resorption. Also, we have to look for the increase of root thickness and length. And some study or some guidelines would like to get the positive sensibility testing. And also the color should be okay too. Therefore, if we would like to see the change of the root thickness and also root length, we have to see the from the radiograph. So there are many groups of researchers that mentions about how to measure the tooth length. For example, there are have to measure the length from this to this, and some measure this and average, and some would like to measure the area of the tooth after generation with this technique. Moreover, they also have some recent recommendation to use a CBCT after the treatment. Okay, so I have some of the cases that I would like to show you. Here is a case with a tooth swelling and a tooth retard with a dent investigation. So if you see from the X-ray, you can see that the tooth itself have a wide root canal with open apex and some periapical lesion. In this case, we use calcium hydroxide as medication, and then wait for 1 month. So you can see something there, right? So in this kind of case, we put too much force on the MTA, so it went through inside the root. However, we can see some of the displacement of the material inside the root. However, the periapical lesion still fine. Okay. After that, we went for a recall period at 5 months, 1 year, and also 1.5 years. You can see a beautiful formation of the tooth root. Even we have a displacement of the MTA inside, it's just okay to be there. But however, there are some literatures mention that placing the MTA or displacement of these materials will generate the worst outcome. However, clinicians should be aware of some things during the treatment. For example, persistent symptoms of the treatment, tooth discoloration, and also calcification inside the tooth. For the discoloration, sometimes we have to be careful of using antibiotics. As I mentioned earlier, that cycline can generate tooth discoloration, so we have to just be careful. The other one is the use of material, which is MTA. Normally, it just can make the tooth color change already, and the staining of the blood inside. So for using the minocycline, we can use other materials instead of minocycline. And for the MTA, maybe we may just use alternative, for example, violentine instead of the MTA. And also for bleeding inside the tooth that may generate tooth discoloration, we may do bleaching after the treatment. Okay. So some study mentioned to use some protector to prevent the penetration of the antibiotics into the dentin by using something that they just generate, like root canal protector, and then just place medicine inside. Another concern is the persistent symptoms after the treatment. The persistent symptoms can be found after the treatment. For example, here is a case of my students that they have to use the regenerative endodontics in this kind of case. In this case, the patient has something done before she came to see her. And then at that time, the tooth came with a white powder inflammation, which we thought that it would be calcium hydroxide. So after that, we think that the tooth should be clean enough, and then we start the regenerative phase. After checking up for 2 months, it seems to be okay in the X-ray. If you can see, we found the burial formation inside the tooth. But however, in this case, the patient presented with a sinus tract after the treatment for 2 months. So it means that some bacterial may left inside the tooth. So we decided to reinfect it again. After root canal re-disinfection, during the day we found that when we opened up the canal, we found some calcified nodules inside without any vital tissues in the tooth. Then we decided to remove it and then re-medicated with calcium hydroxide. After that 3 weeks, follow-up, no sign and symptoms, and we continued the regenerative endodontics. So from this case, it just reminds us that this infection is an important step. So if you are not sure that the tooth itself is clean, so you may better to disinfect it perfectly before doing the regenerative step. So another concern after this treatment is the root canal calcification. Some studies mention that if we follow up this case for a long time, we can find that the tooth have intracanal calcification. Here is an example of 8-year follow-up, and they found that lots of cases that they previously thought that it is successful, they start to have calcification inside the tooth. Not sure, and we don't have enough time. Okay, we just go quickly through. Okay, so up until now there are lots of outcome studies presented to us, and for the overall outcome, so you may like to know that are they good or are they not good? So there is some very recent retrospective study with a larger sample, and then they mentioned that They are pretty good outcome. Let's go quickly. They show high success rate in the treatment after follow-up, and then they found root development and some positive sensitivity response. All of these cases don't have signs and symptoms.